Pulmonary Embolism, presented by Tawab, Brandy, Sid, and Jessa. Objectives. At the end of the presentation, student nurses will be able to define pulmonary embolism and outline the care of a patient with a pulmonary embolism, including the etiology and pathophysiology, clinical manifestations, and management. What is a pulmonary embolism? A pulmonary embolism is a collection of particulate matter, solids, liquids, or air that have become dislodged, obstructing the pulmonary blood flow. This leads to reduced gas exchange, reduced oxygenation, pulmonary tissue hypoxia, decreased perfusion, and potential death. When partial or full pulmonary arterial obstruction occurs, the alveolar dead space is increased. The area continues to receive ventilation, but blood flow is interrupted and gas exchange is impaired. A clot, thrombus, may consist of blood platelets stuck together with glue-like fibrin, red blood cells, white blood cells, or other matter that gets caught up in the clot. Thrombus usually originate in the leg veins or pelvis and may develop from and stick to the inside of the blood vessel, where they grow. Any substance can cause an embolism, but a blood clot is the most common. Fragments, emboli, of this anchored clot may break off and fly away into the bloodstream, causing problems elsewhere. Clots are problematic when they become lodged in the veins of legs, deep vein thrombosis or DVT, and in the arteries of the lungs, pulmonary embolus, PE. Ideally, prevention of PEs are the avoidance of risk factors. Blood clots affect as many as 900,000 Americans each year. They reoccur in 3 out of 10 people within 10 years. As many as 100,000 people die each year from blood clots. A pulmonary embolism is a leading cause of death in women during pregnancy or just after having a baby. Blood clots are the leading cause of death in people with cancer after the cancer itself. Blood clots cost the United States approximately $10 billion a year. Treatment can cost as much as $15,000 to $20,000 per person and often require readmission to the hospital. The risk factors for PE include deep vein thrombosis, venous stasis, smoking, injury to the vein wall, increased blood coagulability, surgery, advanced age, heart failure, history of DVT and PE, immobility, trauma, cancer and cancer treatment, obesity, pregnancy and postpartum period, oral contraceptives, central venous catheterization and hyperviscosity, sickle cell disease and polycythemia.
Physical manifestations of PE range from ambiguous, nonspecific distresses to hemodynamic complications and death. Other clinical manifestations may vary depending on the size and type of the embolism and the region of occlusion. Respiratory manifestations may include dyspnea, pleuritic chest pain, dry or productive cough with blood-tinged sputum. In addition, patients' lung sounds may include crackles, wheezes, rales, or a pleural friction rub. Cardiac manifestations may include tachycardia, distended neck veins, syncope, cyanosis, and hypotension. Life-threatening manifestations such as right ventricular dysfunction and failure, cardiac arrest, and shock may also occur. Other symptoms of PE may include anxiety, apprehension, cardiac murmur, fever, diaphoresis, and hyperventilation related to hypoxia and pain. It is important to remember that many patients with PE do not have the classic manifestations. However, any patient with shortness of breath, chest pain, and/or hypotension without obvious cause should be assessed for PE, and rapid response team needs to be notified immediately.
How is it diagnosed? When a patient presents with clinical manifestation of pulmonary embolism, if able to communicate, the patient should be questioned about onset of symptoms and predisposing risk factors. Also, if family members are present at the bedside, they might be able to provide relevant information regarding the patient's past medical history or risk factors. Arterial blood gases might indicate hypoxemia, hypocapnia, and acidosis. Normal results do not rule out pulmonary embolism. A D-dimer assay can suggest the presence of pulmonary embolism or DVT, but this test does not definitively diagnose pulmonary embolism either. And various conditions such as cancer, pregnancy, infection, older age are associated with elevated D-dimer levels. In addition, radiologic studies can be performed to diagnose a pulmonary embolism. A chest X-ray, spiral CT scan, and/or MRI may show evidence of infiltrates, atelectasis, collapsed lung, pleural effusion, or pulmonary infarction. Ventilation perfusion radionuclide lung scan may indicate ventilation perfusion mismatch. High probability ventilation perfusion indicates a pulmonary embolism. Echocardiography may indicate right ventricular strain and pulmonary hypertension, tricuspid regurgitation, or septal flattening. In addition, an echocardiogram can detect the cardiac cause of hemodynamic instability. Pulmonary angiography is the gold standard diagnostic test and shows blood flow obstruction and provides a near certain diagnosis. Moreover, compression ultrasonography can detect DVT in 1/3 of patients with pulmonary embolism. Contraindications for pulmonary angiography include pregnancy, significant bleeding risk, renal insufficiency, and known right heart thrombus. Risk for mortality associated with angiography is increased in patients with significant pulmonary hypertension or serious comorbid illness.
So treatment's going to start with oxygen therapy, high Fowler's positioning, and getting a cardiac monitor going. IV access should be started right away. Then cardiac and respiratory assessment should be done every 30 minutes, looking for neck vein distension, comparing blood pressure between the left arm and the right arm, checking the quality of pulses, looking at the cardiac monitor to see if there's any dysrhythmias, then listening for lung sounds, checking cap refill, looking at the color of the skin, position of the trachea, all that stuff. Then vitals should be done every 1 or 2 hours, and PTT levels, chest x-ray, and labs should be obtained immediately. And then drug therapy is determined by the presentation and findings of the patient. So the more severe their pulmonary embolism is, the more drugs they're going to get. So they're going to get, depending on what type of pulmonary embolism they have, they could get up to anticoagulants, fibrinolytics, TPA, IV fluids such as crystalloids, and if that doesn't work, vasopressors. Then after they get their drug therapy, they're going to be at risk for bleeds, so continual assessments for bleeding as part of the treatment. And then if those treatments don't work, surgery as an option, embolectomy where the clot is removed. They can mechanically break down the clot with ultrasound or put a filtration on the inferior vena cava. A rapid response would be necessary if the patient reports a sudden difficulty breathing accompanied by chest pain.
Prevention and discharge teaching includes promoting a patient's emotional well-being related to the life-threatening situation that occurred. Assess the patient and family's anxiety level, coping abilities, and knowledge deficits regarding DVTs and PEs. Based on an individualized risk factor assessment, including their knowledge deficits, provide education regarding prevention strategies such as those of the use of compression stockings, avoiding prolonged leg crossing, exercise, weight loss, smoking cessation, proper hydration, and prophylactic anticoagulants for high-risk populations, including those who frequently travel by air. Ensure the patient knows how to recognize the signs and symptoms of DVTs and PEs and the risk and benefits of treatment, including potential adverse effects, bleeding, of anticoagulation therapy. Teach the patient receiving warfarin therapy about the importance of frequent monitoring of INR levels, avoiding foods that are high in vitamin K, green leafy vegetables, along with foods and supplements that can increase the effects of warfarin. Examples are cranberry, vitamin E, ginkgo biloba, glucosamine. Provide the patient information regarding bleeding prevention strategies during anticoagulation therapy, using a soft toothbrush, avoiding razors for shaving. Instruct the patient to seek immediate medical attention if severe bleeding occurs.
Here is a question. The nurse instructs a patient with a pulmonary embolism about administering enoxaparin after discharge. Which statement by the patient indicates the understanding about the instructions? A. I need to take this medicine with meals. B. The medicine will be prescribed for 10 days. C. I will inject this medicine into my upper arm. D. The medicine will dissolve the clot in my lung. Answer is B. Enoxaparin is a low molecular weight heparin that is administered for 10 to 14 days and prevents future clotting but does not dissolve existing clots. Fibrinolytic agents such as tissue plasminogen activator or alteplase dissolve an existing clot. Enoxaparin is administered subcutaneously by injection into the abdomen.
The nurse is admitting a patient with a diagnosis of pulmonary embolism. What risk factors is a priority for the nurse to assess? Select all that apply. Obesity, pneumonia, malignancy, cigarette smoking, prolonged air travel. Answers are A, C, D, and E. An increased risk of pulmonary embolism is associated with obesity, malignancy, heavy cigarette smoking, and prolonged air travel with reduced mobility. Other risk factors include deep vein thrombosis, immobilization, and surgery within the previous 3 months, oral contraceptives and hormone therapy, heart failure, pregnancy, and clotting disorders.
A patient presents at the emergency department with hypotension and is diagnosed with a pulmonary embolism in the category of massive. Which drug therapy should the patient receive as a priority? A. Alteplase, B. Heparin, C. Low molecular weight heparin, or D. Warfarin? Answer A. Alteplase. Rationale: Alteplase is used for the lysis of a large pulmonary embolism in patients who are hemodynamically unstable. Heparin is part of the drug therapy plan for massive pulmonary embolism, but it is most important to promptly administer the clot buster for the large pulmonary embolism. Low molecular weight heparin is used to allow for hospital discharge before switch to oral anticoagulants, not for the emergency department. And warfarin is used for long-term drug therapy, not in the emergency setting. This concludes our learning session.
That concludes our learning for pulmonary embolisms. Thank you for listening. You can find our references in the next few slides.